Hi, everyone. Thank you so much for taking the time to participate in my research study. And also, thank you for learning more about Alpha One Antitrypsin Deficiency. The title of the education module today is An Educational Program to Increase Provider Awareness and Screening of Alpha One Antitrypsin Deficiency. So a little bit of background information on alpha-1 antitrypsin deficiency. This is an autosomal codominant inherited disorder. And what that means is that there are two different versions of genes that are expressed, and each version makes a slightly different protein. Both genes influence the genetic trait or determine the characteristics of the genetic condition. We're going to come back to this slide a little bit later, and I'll explain this more. An estimated 1 in 2,500 people have a form of alpha-1 antitrypsin deficiency. For reference, 1 in 3,400 people have cystic fibrosis. Alpha-1 antitrypsin deficiency is the #1 known genetic risk factor for chronic obstructive pulmonary disease. Unfortunately, alpha-1 antitrypsin deficiency is underdiagnosed. Over 90% of patients are undiagnosed. Those who are diagnosed typically experience a delay between onset of symptoms and diagnosis of 2.5 years. And patients usually see 3 healthcare providers before being diagnosed with alpha-1 antitrypsin deficiency. That's a long time to have symptoms and to not have a diagnosis. Alpha-1 antitrypsin deficiency is characterized by the production of an abnormal alpha-1 antitrypsin protein. The liver makes most of the circulating alpha-1 antitrypsin in the blood. So for a person who's deficient, the liver is not producing enough of this important protein, and in some cases, it's producing it abnormally, and so it can't exit the liver correctly. Alpha-1 antitrypsin protects tissues of the body, especially lung tissue, from being damaged. And without that protective protein protecting the lungs, it can lead to COPD and liver diseases and other health-related conditions. For purposes of this research study, I'm focusing on COPD and lung-affected problems. Who should be screened for alpha-1 antitrypsin deficiency? In 2003, the American Thoracic Society recommended that all patients with COPD be screened for alpha-1 antitrypsin deficiency. Despite the amount of time that's passed since that recommendation, and it has not changed throughout any of the years, there has not been an increase in screening for alpha-1, and there has not been an increase of diagnosing of alpha-1 antitrypsin deficiency. And this recommendation is regardless of age, ethnicity, or smoking history. Again, all patients with COPD should be screened for alpha-1 antitrypsin deficiency. So how do we screen for this condition? There are 2 different ways that you can screen for this, but it's important to remember that diagnosing alpha-1 antitrypsin deficiency is a laboratory diagnosis, not a clinical diagnosis. You must screen for this by either doing a blood collection or using an alpha ID kit. The first method that we're going to talk about is a blood collection. There are 2 tests that are needed to make this diagnosis. The first is an alpha-1 antitrypsin level, which tells us how much AAT is in the blood. But doing this test alone is not enough. This level can vary, like if somebody's sick, it can be higher or lower. And also, it does not provide definitive results in individuals who only carry a single abnormal gene. And so you really need the AAT level and the phenotype level to make this diagnosis. The phenotype is what can tell us if they're MM result or ZZ, which we're going to talk about here in a second. Below, you can see the information on how to order the test, the codes to use, CPT codes, and what type of tubes to collect the samples in for your reference. If you do use blood collection as your method for screening, the results take about 4 days to come back. The second method for testing is to use an Alpha ID kit. These are kits that are free and are available from augmentation therapy manufacturers, which we're going to talk more about augmentation therapy in a couple of slides. This is a non-invasive cheek swab. It only looks at the phenotype. To get a kit, you can contact one of the manufacturers and they will either deliver or mail kits to your clinic. And the kits come with a form that needs to be filled out that takes about 2 to 3 minutes. It asks for patient demographics, an NPI number, and a provider signature. And then it has the little swab that you can use to collect the sample, put it back in the tube, and mail it back in the provided envelope. If you use this method, it takes about 1 to 2 weeks to get the results back. I also have testing kits available. So on my study website, you'll see a link that says send me a kit, and I would be happy to mail you Alpha One Antitrypsin Deficiency ID kits that you can have in your clinic. The results are back, and I want to help you interpret the results. So normal alpha-1 antitrypsin level can depend on the lab and also the reference range and the unit of measurement that the lab uses. But roughly it's 100 to 250 milligrams per deciliter, or 19 to 53 UMs. The phenotype interpretation is a little bit trickier. On the left-hand side, you can see the list of phenotypes and then what they mean, and we'll go over each one briefly. MM is normal. If your patient comes back with an MM phenotype, it's a good day for them. This person does not have alpha-1 antitrypsin deficiency. SS is a positive result. This person does have alpha-1 antitrypsin deficiency. The SLE produces moderately low levels of alpha-1 antitrypsin protein. ZZ produces very low levels of alpha-1 antitrypsin protein. This person does have the disorder and is likely to develop symptoms, especially if they have lifestyle risk factors. This is the most common severely deficient phenotype. SZ is also a positive result. This person does have alpha-1 antitrypsin deficiency. However, this phenotype is less common. MZ and MS have one normal allele, the M, and one abnormal, the Z or the S. The normal M allele may produce enough protective factor to protect the lungs and the liver, and especially with no lifestyle risk, these patients are likely to be asymptomatic. However, there are many MZs, MS who do develop symptoms, and this phenotype needs more research. Z null, null null, FF, and FC are much less common phenotypes. These are all deficient, and patients do have alpha-1 antitrypsin deficiency if they have any of these phenotypes. So going back to our Punnett square, so you can see here that the top, the parents, mom and dad, are both MZs. Again, they have that M allele, which is protective for most people, and the Z, which is abnormal. Again, because they have that M, they may not develop any symptoms, but out of their 4 children, they have one child who's MM, who's normal. The person does not have alpha-1 antitrypsin deficiency. And then 2 children that have MZ, they have one normal, one abnormal. Again, may not develop symptoms. And then they have that 4th child, ZZ, with 2 abnormal genes who are more likely to get symptoms out of all those 4 children. So for someone who has alpha-1 antitrypsin deficiency, lifestyle changes should always be recommended. Smoking cessation is imperative for these patients. Smoking cessation immediately. Please educate your patients on the importance of stopping smoking immediately if they have alpha-1 antitrypsin deficiency. They should also avoid chemical exposure and exercise and have a healthy BMI. Important things for all patients. One of the identified barriers in screening for alpha-1 antitrypsin deficiency has been the belief that there is no treatment for this disorder, and that is not true, especially for patients who are lung affected. There is treatment for lung affected patients with alpha-1 antitrypsin deficiency, and the treatment is augmentation therapy. Augmentation therapy is a plasma-derived alpha-1 antitrypsin protein infusion that the patient will receive in a weekly infusion, hopefully for the rest of their life. It is proven that augmentation therapy works. Augmentation therapy has been proven to slow down progression of lung disease, and there are many patients who have been on it for 10, 15 years and have lived relatively healthy and normal lives. It's so important to identify patients with alpha 1 antitrypsin deficiency because the earlier we can start appropriate patients on augmentation therapy, the better off those patients are going to be and the better outcome they're going to have. And again, it will help to delay the progression of lung disease. These are my references. Thank you so much for your time and for your attentiveness. I appreciate it. Thank you.